Malignant tumors of connective tissue origin. So after seeing the malignant neoplasm arising because of epithelial cells or epithelium or epithelial melanocytes or epithelial cells, malignant epithelial cells, we'll see the tumors or neoplasms arising because of defects or origin from the connective tissue. Okay. First, we'll see the fibrosarcoma. As we have already seen, fibroma is a benign tumor of occurring of connective tissue origin. It is just related to fibrous hyperplasia. That was a benign neoplasm. When the sarcomatous changes, that is the malignant changes, are seen along with fibroblastic activity, that denotes the term the fibrosarcoma. Basically, fibrosarcoma, it is a malignant neoplasm occurring exclusively in the soft tissues. Okay. Here if we see, as the name indicates, fibrosarcoma, it is composed of malignant fibroblast in a collagenous connective tissue background. Basically, the fibrosarcoma is the exclusive malignant neoplasm which is occurring or which shows features only in the soft tissue. Fibrosarcoma, it is of two types, primary and the secondary fibrosarcoma. Primary fibrosarcoma is because of malignancy arising because of excessive production of collagen, whereas secondary fibrosarcoma, it arises because of presence of any neoplasm previously. Okay, some neoplasm was present previously in that particular same region, it got aggravated and formed the fibrosarcoma, that is malignant fibroblast become transformed in the previous occurring neoplasm. That is nothing but a secondary fibrosarcoma. We know the fibrosarcomatous lesions, basically they are more common in men in the 4th decade of life, and predominant lesions of fibrosarcoma occurring in soft tissue and more commonly which affect the bone are seen in lower extremities or lower limbs, especially the femur, the tibia, the skull, the clavicle, even the jaws. The jaws are relatively less commonly involved, but mandible may be involved. Okay. So the appearance of fibrosarcoma lesion is seen. When the fibrosarcomatous lesion is involving only the soft tissue, it occurs as a painless mass which is just situated deeply in the tissue. And this large painless masses, they may be present deep to the fascia. And because they are ill diffuse or diffuse in nature, are situated deeply, they do not have a distinct nodular appearance as seen in cases of fibromatous lesions. Okay, fibroma, oral fibroma, it was appearing as a nodular lesion. So here the margin is not defined, it is just appearing deep to the facial tissue, deep to the muscles, it is deeply situated lesion. Okay, when the sarcomatous lesions or the fibrosarcomatous involve bone, only then they are associated with extreme pain, severe swelling of the associated tissues, excruciating pain is present. So that are the features, clinical appearances of sarcomatous lesions. Okay, now when we see the lesion and when we send it for biopsy and when we study the microscopic picture of a fibrosarcomatous lesion, as I told you, essentially malignant fibroblasts predominate in a collagenous connective tissue background. Based on the appearance of the fibroblast, okay, the fibrosarcomas are divided based on the grading into well differentiated and less well differentiated or low grade tumors. The well differentiated tumors, here the fibroblasts are present with the plump fibroblasts are present which are multiple in number, and when we see the characteristic cell of fibroblast, it shows a pale eosinophilic cytoplasm. Along with that, the nuclei will be deeply stained and the ends of the fibroblast will be just tapered spindle shaped ends. Okay, and the malignant cells are just dispersed in a collagenous connective tissue background. These are the well differentiated tumors. Well differentiated tumors, so well defined malignant fibroblast with the spindle shaped nucleus and eosinophilic cytoplasm. Whereas the intermediate cell tumors or the intermediate grade fibrosarcomas, they are relatively cellular and they have a typical herringbone pattern, that is the spindle shaped cells or the fibroblast cells, they are arranged in concentric walls or spindle or circles, giving the characteristic herringbone pattern. The high grade lesions or the high grade tumors are very cellular, they are extremely atypic. Features are present, that is the pleomorphic features are present in the malignant fibroblast, and the mitotic activity is very severe, there is increased nuclear cytoplasmic ratio is present. All features which indicate malignancy are present in case of high grade tumors. Okay, so the treatment for any fibrosarcomatous lesion essentially involves surgical excision. X-ray radiation may not be of that important in case of fibrosarcomatous lesions. Okay, whenever the term sarcoma is used, it indicates underlying malignancy. Okay, only the appearance of fibroblast is different when we see histologically and clinical pictures also. The soft tissue lesions present a painless one. Only when it is involving the bone, it is associated with swelling and pain. So that's about the fibrosarcoma. We'll see the osteosarcoma. As I told you, malignant neoplasms of connective tissue origin, specifically they show clinical manifestations and which are more severe when involving the bone. Osteosarcoma is nothing but a malignant neoplasm of the bone. It is the most commonest neoplasm. It is the third most cancer seen in cases of adolescents. It was previously known as osteogenic sarcoma. So the name osteosarcoma, it indicates that a malignancy of neoplasm is there, which is showing osteoid deposition by proliferation of osteoblasts. Malignant osteoblasts form, they deposit the osteoid, giving rise to the osteogenic sarcoma. Basically the malignant neoplasm or malignant osteoblast, they just proliferate along the long bones of the extremities, femur, fibia, long bones of the limbs. More commonly in the epiphyseal or the metaphyseal growth plates will be present. There you can see excessive deposition of this osteoid tissue. Incidence of osteosarcoma is relatively higher in cases of males when compared to females, and basically this is the third most common cancer in adolescents. So more characteristic or severe symptoms are seen in case of children and adolescents. Clinical features of swelling and pain associated with that particular bone may be seen, and because of the extreme swelling and pain, it leads to inability to movement with that particular bone, and patient may be complaining of a sprain, of arthritis, or a severe groin like excruciating pain in the particular involved bone. More commonly long bones show, and when coming to the oral cavity, mandible is more commonly involved when compared to the maxilla. Along with that, generalized body symptoms of fever, chills, night sweats are present. Systemic symptoms, weakness may be present. As I told you, it's basically a disorder of osteoblasts. Osteoblasts show excessive proliferation at the metaphyseal growth phase, so long bones are commonly affected, and when coming to the oral cavity, mandible is more commonly involved. It just presents as a swelling of the involved area. This swelling is associated with characteristic facial deformity because of the swelling and excruciating pain, and the area involved, it shows loosening of all the particular teeth involved, and paresthesia of that particular area. Odontogenic tooth pain will be present along with bleeding from that particular area. When you see the radiographic picture only, you will know the characteristics of the underlying deformity or defect which is causing all these clinical symptoms of mobility, paresthesia, and swelling. Okay. Basically osteosarcoma, based on their appearance, at the level of appearance, they are known as the paraosteal or juxtacortical osteosarcoma. It is relatively common neoplasm. It does not show any tendency for metastasis. Here the appearance of swelling or appearance of characteristic lesion may be just limited to the cortex region. It does not show excessive invasion. Whereas the periosteal osteosarcoma is nothing but the extension of that paraosteal osteosarcoma or the sarcoma of the paracortex into the underlying connective tissue, into the underlying more deeper structures, medullary spaces. Whereas the extraosseous osteosarcoma is nothing but the appearance of osteosarcoma in the soft tissues of the long bones. When you see the radiographic appearance of this osteosarcoma, as I told you, osteosarcoma, basically they present varied clinical presentations. In the initial symptoms, there will be osteolytic activity will be seen, so radiolucency will be seen. As it is a disorder of osteoblast starts proliferating, and once they deposit the tissue, you get to see some of the radio-opaque area. So mixed radio-opaque, radiolucent lesions may also be seen. But the characteristic features or symptoms of this osteosarcoma is the characteristic sun ray appearance when seen in the radiograph. That is nothing but osteoid deposition occurs from the cortex and it extends towards the outer surface of the cortex. There is small streaks of bone appear to be radiating outward, so that giving the term sun ray appearance. Even you can see the radiograph there. It's showing a radiolucent bone with the metaphyseal end plate is present. It is showing a characteristic radiolucent area. Along with that, if you see the radiolucency, inside the radiolucency, you can see osteoid deposition. Few radio opacities or radio opaque lesions are present. radio opacity is present within the radiolucency. That is the nothing but the osteoid deposition. And sometimes what happens is whenever the osteoid deposition is occurring in cases of mandible, when it's involving the teeth, there is extreme widening of the periodontal ligament space. There is a resorption of the adjacent bone occurring because of the initial radiolucent activation. And the periosteum of the bone, it just tends to be elevated above the surface of cortex. Okay, and the osteoid deposition is occurring inside, the periosteum is elevated, giving the characteristic tent shape appearance. Okay, because the periosteum is elevated, it's giving a tent shape appearance. That has been given the term as the Codman's triangle. What happens is whenever the periosteum is elevated, it just forms an acute angle with the corresponding cortex of the bone. Okay, so that the acute angle is formed, that has been given the name Codman's triangle. So when you see the microscopic picture, as I told you, it's essentially a neoplasm of proliferation of the osteoblast. So atypical osteoblast may be seen bordering the lacunae of the bone. The trabeculae will be irregular. They may be just bordered by the osteoblast. These osteoblasts lead to deposition of osteoid. And the connective tissue cells may be spindle shaped columnar cells which are normally seen in the bone. So that is about the microscopic picture. There are different forms of osteoblastoma or osteosarcoma based on the cell which is predominant there. If osteoblastic activity is prominent, it is known as osteoblastic sarcoma. If the conventional variety is nothing but which is showing large multinucleated gained osteoblast-like cells, which are showing the characteristic neoplastic features of extreme enlargement of the cell nucleoli and extreme hyperchromatism and nuclear pleomorphism. Okay, basically multinucleated gained cells will be present. The treatment for osteogenic sarcoma is nothing but amputation of the involved bone because the involved bone may have completely shown the malignant invasion of the osteoblast, right? So it has to be just excised or removed completely. If the metastasis is involving the lymph nodes, then it's more of a concern. The patient have to be put on chemotherapy and other drugs. Okay, now we'll see the other malignant neoplasms. That is there is one neoplasm which is chiefly involving the malignancy in the lymphoid tissue or the lymph nodes or lymph organs. That is nothing but the malignant lymphoma. Basically, all the malignant lymphomas are proliferative disorders of the lymphoblast, lymphoid cells and the lymph nodes. Lymph organs basically show this characteristic proliferation of the lymphocytes. So we'll see the disorder involving the lymphomas or the lymph nodes. Non-Hodgkin's lymphoma, it is relatively more common of a malignant neoplasm. It is basically a heterogeneous group of lymphoproliferative disorder. As the name indicates, lymphoproliferative disorder. Proliferation of lymphocytes is uncontrolled proliferation is seen here. Okay, this proliferation can involve the individual lymph nodes as well as the lymphoid organs or tissues also. The etiology for this is nothing but any form of mutation occurring either at the gene level or the chromosomal level, or any environmental factors may be suggested at causing this, or any viruses like Epstein-Barr virus, human immunodeficiency viruses may be the causative, or sometimes immunosuppression makes the individual just prone to development of these cancers, or individuals who have already undergone radiotherapy and chemotherapy for treatment of any other neoplasms are more prone to develop this kind of lymphoproliferative disorders at a later stage in their life. Okay, basically this lymphomas are seen in case of older age individuals older than 50 years of age. Obviously above 50 years of age, the immunity of the person is little bit decreased, and if such an individual who has already undergone a radiation therapy or a surgery for any neoplasms, he is very immunocompromised state. He is very immunocompromised in nature, so he is more prone to develop this lymphoma, non-Hodgkin's lymphoma. Initially, the characteristic features of lymphoproliferation, that is proliferation of lymphoid, is nothing but enlargement of the lymph nodes. So lymphadenopathy is seen. Lymphadenopathy may involve the cervical lymph nodes, the axilla, the inguinal. Wherever in body you can see the deposits of lymph nodes all show the characteristic enlargement initially. Lymphadenopathy, which may be painless in nature. painless but palpable lymphadenopathy will be present. So systemic symptoms of fever, lymphadenopathy, night sweats, weight loss, fatigue, and itching or pruritus may be seen. And along with that, organ specific symptoms such as if the lymphoproliferation, it's involving the tissues or organs of the body, if the proliferation of cells is seen and it's involving the other systems, then you see the systemic symptoms of cough, chest pain, shortness of breath, and abdominal pains because of involvement of the organs, lymphoid organs. When you characteristically see the oral cavity in case of lymphomas, the oral lesions may just appear as a nodular lesions which are painless, sessile, 0.5 centimeter in diameter. Sometimes they may show proliferation or ulceration, and they grow very, very rapidly. Oral manifestations of the disease are relatively uncommon, and sometimes only the oral manifestations may be present along with lymphadenopathy. When you undertake a biopsy only of the lymph node only, you will get to know about the lymphoma. So that oral lesions are seen. Okay. Initially they may present as a nodular lesions which are painless. Sometimes large fungating masses or necrotic foul smelling masses may be seen in the oral cavity, which you send for histopathological examination, and you see that the proliferation of lymphocytes are seen. Associated with the development of such masses, tooth mobility is seen in the involved area, and as the mass is present and regional lymph nodes are also involved, pain is obviously present. So now we have seen the clinical features of the non-Hodgkin's lymphoma, the characteristic general symptoms, the organ specific symptoms, and the oral cavity appearance. Now we'll see the histologic patterns. Histologic pattern of Hodgkin's lymphoma may be different based on their group or arrangement of the lymphocytes. Okay, based on the arrangement of lymphocytes, based on the characteristic spread of the cells. The non-Hodgkin's lymphoma may be a nodular showing a nodular pattern or a diffuse pattern. In the nodular pattern, what happens is the neoplastic cells or the proliferative lymphocytes, they may be just arranged in groups of cells or clusters of cells. In the diffuse pattern, no such arrangement is seen. The neoplastic lymphocyte, they just tend to be arranged or distributed at a rapid phase in the connective tissue of the lymphoblast. Yeah, nodular or geminal center formation is absent in case of diffuse lymphocytes or the diffuse pattern of this non-Hodgkin's lymphoma, whereas a characteristic nodular proliferation of lymphocytes along with the geminal center. The geminal center is nothing but the place from where lymphocytes arise. Okay, so it is seen in case of nodular pattern. Treatment for this is a lymphoproliferative disorder is a radiotherapy or a chemotherapy. The patient already he has gone a surgical excision, but if the lymph nodes or of all of the body are involved, they characteristically have to go for surgical excision along with radiotherapy and chemotherapy. And there is one specific form of lymphoma known as African jaw lymphoma or Burkitt lymphoma, originally described by the author Burkitt. Basically, this African jaw lymphoma, it is an endemic form of Burkitt lymphoma occurring only in the African countries. So the name itself is indicating that the characteristic features of this form of lymphoma are seen only in case of jaws. And there are basically two forms of the Burkitt lymphoma. The high grade it is a very, very high grade B cell neoplasm. That is nothing but the proliferative cells or the lymphocytes, whatever are present, they are of B cell origin. Okay, the two forms, there is endemic and the sporadic form. The African form is the endemic form, which is known as the African jaw lymphoma. It basically involves the maxilla and the mandible. The clinical features of pain, swelling may be present with the affected facial deformity. Along with the pain, swelling of the region may be seen. There will be loosening of teeth in that particular area. Characteristic regional lymphadenoma may be present. Though the swelling is of a huge size, it is non-tender in nature and it is a rapidly growing swelling. And more characteristically, African jaw lymphoma affects only the children and the younger adults, very, very young age. As you can see in the clinical picture, the characteristic enlargement of that particular swelling is seen, which is involving both the maxilla and the mandible. Regional lymph nodes are also involved in such cases. The sporadic form of this Burkitt's lymphoma is nothing but a more diffuse form. along with the involvement of lymph nodes, it also involves, it also presents the characteristic clinical symptoms in the abdomen. Abdominal organs may be involved, like the kidneys may be involved here. Distal ileum, cecum, mesentery, all may show the lymphoproliferation. Okay, initially this sporadic form, it presents as abdominal tumors or swelling. Along with that, characteristic pain may be present and bowel obstruction is present. So the African jaw lymphoma is more commonly manifested in jaw, whereas the sporadic form of Burkitt lymphoma is manifested in the abdomen as abdominal tumors, along with the characteristic features of regional lymphadenopathy. When you see the microscopic picture of Burkitt's lymphoma, as I told you, Burkitt cells, the name given to the lymphoproliferative cells, they are actually very small in size, homogeneous in shape. They will be equal in all aspects, the Burkitt cell size. And they have a small round to oval nuclei with clumping of chromatin at one end. And nucleoli may be more in number, indicating the features of this dysplasia or dysplastic features. And when stained histologically, they show vacuolated cytoplasm, though multiple nuclei are present and nuclei is present, round nuclei is present. The cytoplasm of most of the cell is just scanty. Okay, and along with that, proliferation of macrophages may be present, giving the characteristic appearance of starry sky, because the macrophages are present and which are just scattered. Abnormal macrophages are present which are scattered, and even the cells show the scanty cytoplasm. Treatment for this particular form of lymphoma includes excision, surgical excision of the associated swelling, along with the characteristic removal of all the lymph nodes or the lymphoid glands, and chemotherapy. The patient is put under the chemotherapy, and it produces, though there are very lesser chances of recurrence of this condition. The patient has to be kept under observation for because of future recurrence of the disease. And now we'll see the Hodgkin's disease. Hodgkin's disease, it's also known as Hodgkin's lymphoma or malignant lymphoma. As I told you, all the malignant lymphomas are nothing but the proliferation of the malignant lymphocytes or the lymphoblasts, as they are called. The etiology for this Hodgkin's disease is nothing but, as I told you, environmental factors are responsible, genetic factors are responsible. Sometimes Epstein-Barr virus etiology has been induced. And Hodgkin's disease is more commonly associated with HIV-induced proliferation of epithelial cells. So HIV virus is associated with this Hodgkin's disease. And when you see the clinical features of Hodgkin's disease, it's characteristically bimodal in distribution. That is, at two particular ages, more commonly this disease features of Hodgkin's lymphoma are seen. That is, that one age group includes the adult, that is about 15 to 34 years of age, are more prone to develop. The other is the older age group above 55 years of age in immunodeficient states. Initially, there is painless enlargement of one or more regional cervical lymph nodes, and they may be palpable. Okay, the cervical lymph nodes are involved more commonly, about 60 to 80%. Axilla is involved less commonly, only 20% cases of axillary lymph node enlargement are seen. When you see the generalized, when you palpate the lymph node, the nodes are relatively firm and they are rubbery in consistency. They appear to be hard in nature. When you see the cervical lymph nodes are painless, but they are palpable. So they appear to be relatively firm and rubbery in consistency. As with other lymphoproliferative disorders, systemic features of weight loss, fever and night sweats may be present, and generalized associated symptoms of cough, chest pain and shortness of breath may be seen. The oral cavity also presents few features of this lymphoma. That is, the painless sessile mucosal nodules may be present. Very rarely, only occasionally painless this nodules may be present. So when we see the clinical features of enlargement of regional lymph nodes which are painless but palpable and associated with generalized body symptoms of fever, chest pain, cough, breath, shortness of breath, then you have to just identify the underlying disease. Okay, when you study the microscopic feature of this particular Hodgkin's disease, you see that there is proliferation of lymphocytes which are arranged in characteristic different patterns. That is based on the cell which is predominant in the microscope, it is being divided into different types. This Hodgkin's disease. The nodular sclerosis variety, it's basically the lymphoid organ. It's basically showing broad bands of fibrosis which divide the lymph node into a nodules. But the broad bands of fibrosis divide the lymph node into some nodules. The fibrosis present, there is thickening of the capsule of the lymph node, and the characteristic cell of this nodular sclerosis is the Reed-Steinberg cell. Reed-Steinberg cell is nothing but an enlarged lymphocyte or a lymph node lymphoid cell, which is basically having a monolobated or a bilobated nuclei with the characteristic eosinophilic staining of the cytoplasm. Here, the Reed-Steinberg cell is basically enlarged lymphocyte, and the few of the cytoplasm will be scanty, and it will be stained eosinophilic. It will have a single nucleus, or it will have a two lobes, and in that two nuclei may be present, or a single nuclei may be present. Okay. So a enlarged abnormal lymphocyte we can call. The Reed-Steinberg is an abnormal lymphocyte. So that's about the nodular sclerosis variety. The mixed cellularity shows the presence of an infiltrate of lymphocytes of all variety. Along with that, the Reed-Steinberg cells are present. They may be having a bilobe nuclei. Okay. And mixed cellularity. The name indicates that the infiltrate is diffuse in nature. It's of mixed variety. Both the T lymphocytes and the B lymphocytes predominate here. Now the lymphocyte depleted variety, it's seen in only 1% of cases of Hodgkin's disease, and here the infiltrate, even though it's diffuse in nature, it appears to be showing reduction in the number of proliferative lymphocytes, and the Reed-Steinberg cells are present, which are same abnormal and monolobated or bilobated nuclei. The lymphocyte depleted variety, it's more commonly associated with HIV affected individuals, that is the HIV infected immunocompromised individuals. They show this lymphocyte depleted variety because there is already immunodeficiency state, and the lymphocytes are very reduced in number. The lymphocyte rich variety is seen in about 5% cases of Hodgkin's disease. Here there is along with abnormal proliferation of lymphocytes, abnormal lymphocytes are present. Along with that, the lymphocytes tend to be more increased in number, both the B lymphocytes and T lymphocytes. The Reed-Steinberg cells are seen in the classic variety, as we have seen in the nodular sclerosis variety. Rich infiltrate of lymphocytes is present. The nodular lymphocyte predominant variety, it is the most commonest variety of Hodgkin's disease. About 5% cases show this Hodgkin's disease show this nodular lymphocyte predominant variety. Here the only characteristic features is the Reed-Steinberg cells are not seen. Instead of that, a variant of Reed-Steinberg cell is seen. Reed-Steinberg cell is nothing but an abnormal lymphocyte. Again, here the variant of Reed-Steinberg cell is nothing but an abnormal variant of the normal lymphocyte, that is known as the lymphocytic and histiocytic cells, also known as the popcorn cell or the kernel cell. Here what happens is the nucleus or the abnormal lymphocyte, it resembles the exploded kernel. Okay, there is a popcorn cell, as it is called, exploded popcorn like a thing. That is known as LNHL, and in rich infiltrate of inflammatory cells, there is lymphocytes, plasma cells are common. So that's all about the Hodgkin's disease. Again, the treatment for Hodgkin's disease includes the surgical excision along with radiotherapy and the chemotherapy. Now we'll see the other commonest malignant neoplasm, that is the Chondrosarcoma. Chondrosarcoma, as the name indicates, a malignancy involving the cartilage. We have seen that benign neoplasm arising in the cartilage tissue, that is the chondroma. So this is the malignant variant of that particular chondroma. The clinical features of the chondroma and chondrosarcoma appear to be similar, only histologically they are different, because these the cartilage cells, they are extremely malignant and show characteristic typical mitotic features in case of the chondrosarcoma. Basically, the chondrosarcoma, it is a variant of a benign chondroma. Primary chondrosarcoma is something which is arising de novo, that is, it arises on its own without any previous association with the chondroma, and it's seen in the extraskeletal tissues or in the other proliferative places that are known as teratomas, proliferative tumors. So that's about primary chondrosarcoma. Secondary chondrosarcomas are nothing but tumors which arise in other neoplasms like fibrous dysplasias, osteochondromas, osteosarcomas. If tumors arise in such instances, they are known as the secondary chondrosarcoma. No characteristic clinical signs and features of chondrosarcoma are seen. As we have seen in the benign chondroma also, there were no characteristic clinical features. This tumor occurs at any age. Basically, they are based on the level of proliferation of cells. They are divided into high-grade tumors. The high-grade tumors, that is rapidly growing tumors, are present. Only then they are associated with severe excruciating pain. The tumors are of low-grade proliferation. They just appear to be a painless swelling of that particular region and no associated pain is present. Metastasis of this chondrosarcoma, it is relatively rare. Though it is a malignant neoplasm, metastasis occurs at a very later stage. Okay, so what are the varieties or variants of chondrosarcoma seen? The chondrosarcoma basically based on the proliferation of cells. It's divided into the mesenchymal chondrosarcoma, clear cell chondrosarcoma, and the dedifferentiated chondrosarcoma. The mesenchymal cell chondrosarcoma is nothing but a chondrosarcoma. There is a malignant neoplasm arising in the connective tissue that is extremely cartilaginous in nature. Basically, it is a disorder involving the cartilage, right? So, mesenchymal chondrosarcoma, it is more commonly seen in the age group of 10 to 30 years of age, and the clinical characteristics are more seen in the jaws, mandible region. Whereas the clear cell chondrosarcoma, basically what happens is, here the cartilage cell, it appears to be having a scanty cytoplasm with eosinophilic stained nuclei. So that's giving the appearance of a clear cell, and here it's a very low growth pattern. That is the tendency to metastasize is also very low, and it is a very slow growing tumor. When we see the dedifferentiated carcinoma, basically it is a mixture or a combination of a low grade chondrosarcoma and a spindle cell carcinoma. Spindle cell carcinoma is another variant which is showing the proliferation of spindle cells. It is a spindle cell carcinoma. Then the low grade differentiated sarcoma, differentiated chondrosarcoma is nothing but the proliferation of cells which are not associated with extreme malignant features. Okay. Oral lesions, when you see the characteristic presentation of painless swelling in the oral mucosa, okay, that's showing the feature of chondrosarcoma. Only on histologic examination you can give a diagnosis of chondrosarcoma. So the mucosa overlying the lesion is intact. The tumor sometimes it may spread and involve the maxilla or the mandible. When it is involving the bone, then only it is associated with resorption of the alveolar bone and exfoliation of the teeth. So the treatment for these are the clinical features and the radiographic features of this characteristic chondrosarcoma is nothing but when it is involving the bone, osteoma, when it is involving the bone, the resorption of that particular area is seen, and occasionally it is radio opaque. Most of the times, occasionally radiopacities may be seen. And when you see the microscopic picture, as I told you, it is basically a disorder of cartilaginous tissue, mature cartilaginous tissue. So, different sheets of chondrocytes may be seen scattered in the connective tissue. These sheets of chondrocytes, they may show a lobular growth pattern. When you study the mesenchymal cell carcinoma basically shows small, round or ovoid undifferentiated cells, chondrocytes only, which are very small, which are oval, which have a oval round nuclei, which are arranged in which are distributed in the connective tissue. The small, round, ovoid chondrocytes are distributed in the connective tissue. They are uniform in appearance. The clear cell variety, as I told you, they are nothing but the gained cells which are having a clear cytoplasm. The cartilage cells, which are relatively larger in size, with a small nuclei and which is showing a clear cytoplasm. Dedifferentiated chondrosarcoma is basically a mixture of low grade chondrosarcoma and a high grade spindle cell carcinoma, as we have seen in the clinical features also present the same. And the histologic picture, if you can see there, the H&E, hematoxylin and neosin staining, you can see that the sheets of chondrocytes are just scattered in the connective tissue. Treatment for chondrosarcoma involves the surgical excision of the involved swelling, and it leads to spontaneous regression. Metastasis is very rare in case of chondrosarcoma. Ewing sarcoma. It is another common malignant neoplasm involving the bone. It's basically also known as a round cell tumor. Basically, what happens is here, a lot of authors correlated Ewing sarcoma to be arising because of a neuroectodermal in origin. They just correlated Ewing sarcoma with a primary primitive neuroectodermal tumor. But now it is well established that it is a defect of round cell. It's also known as a round cell tumor or a round cell sarcoma or a endothelial myoma. What happens is here the cells appear to be round in nature histologically, hence the name round cell sarcoma. This is basically a tumor involving the bone of children and young adults in the age group of 5 to 25 years. The osteoblasts, they appear to be small, round in size. This Ewing sarcoma is more common in males, twice as common in males as compared to the female. Characteristic feature of Ewing sarcoma is an episode of trauma or history of trauma will be present prior to the development of a swelling. The trauma may be present at any stage. At a later stage, it may develop into swelling and characteristic excruciating pain will be present, but the pain is not continuous. It is of intermittent in nature, and along with the pain, the swelling of involved bone is seen. We have seen that in almost all the malignancies, pain is a characteristic feature associated with the swelling of that particular region. Only on histologic examination, you will know that it's a tumor arising because of the defect in osteoblasts. Okay. The Ewing sarcoma, initially it was first detected in the long bones of the extremities, the skull, clavicle, ribs, shoulder, and at a later stage maxilla and mandible also showed this characteristic Ewing sarcoma. So here you can see the characteristic Ewing sarcoma, the radiographic appearance. The radiographic appearance is unique in that there is it is a disorder of osteoblast. So diffuse layers of osteoblast appear to be bordering the periosteum and they show the characteristic deposition of osteoid. Layers of new bone subperiosteally, so giving the characteristic new skin or the onion skin appearance. Extremely radiolucent lesion is seen initially, which is just bordered by the osteoblast. So the subperiosteal bone deposition occurs in layers, and the cortex is infiltrated by the tumor. If it's involving the mandible, the cortex is infiltrated. It shows the characteristic deposition of osteoid on the cortex, and when you take a radiograph, it appears to be the rays of osteoid arising from the cortex. That is nothing but the sun ray appearance as we have seen in the osteosarcoma. It is also seen in the Ewing sarcoma. But the onion skin appearance is more specific to Ewing sarcoma only. Okay, along with the clinical symptoms of jaw, pain, swelling, the patient has a elevated blood cell count and a low grade fever associated. When you see the microscopic picture of Ewing sarcoma, basically it's the osteoblast. They tend to be arranged in sheets or masses of small round cells. The tumor cells are nothing but sheets of small round cells which are just distributed within the little stroma, and the cells they are characteristic in that the cytoplasm is a little bit scanty which are having a round large nuclei, and when stained with H&E staining they appear to be hypochromatic, that is darkly stained in nature. Okay, small round cells with the oval nuclei which are hyperchromatic in nature and has a scanty cytoplasm, and the borders of the cell tend to be indistinct in nature, as you can see in the clinical picture there. Okay, in the histological picture there, sheets of cells are seen. These are nothing but osteoblast, excessive proliferation is seen. Treatment for this Ewing sarcoma is nothing but surgical excision of the involved bone. Amputation of the involved bone is carried out. If the swelling is present, it is surgically excised along with the border of normal bone to just make sure that there are no underlying or cells present which may cause recurrence again. multiple idiopathic hemorrhagic sarcoma of Kaposi. As we all know that Kaposi sarcoma, it is actually a proliferation or multicentric proliferation neoplasm of the endothelial cells. So there is a defect in endothelial cells here which is leading to the proliferation, and Kaposi sarcoma as commonly associated with HIV. We know that. But there are initially the author Kaposi, when he proposed it, he gave the term idiopathic sarcoma of Kaposi of skin. It was originally meant for skin. Later on, it was noticed in other sites also. There are classically 4 variants of this Kaposi sarcoma. One is the classic variant, another is the lymphadenopathic variant, and there is a transplantation associated and HIV associated variant. The clinical picture of all variants will be different. The etiology is nothing but any genetic mutation which is more commonly associated with immunodeficient states leading to development of this neoplasm, previous history of radiotherapy, surgery, or HIV infection. The classic or chronic form, it presents the cutaneous manifestations of multifocal blue or red nodules which are more commonly seen on the lower extremities, and they just tend to be increasing in size. So that's the classic variant of the Kaposi sarcoma. When you see the oral cavity of the patient with this cutaneous nodules, you see soft bluish nodules may be developing on the gingiva or the alveolar mucosa or the palatal mucosa. So when we see the lymphadenopathic variant, as the name indicates, lymphadenopathic, so there is characteristic associated regional lymphadenopathy is present. There is localized or generalized enlargement of lymph nodes is seen. So the associated cervical lymph nodes are enlarged. Along with that, the characteristic clinical presentation of nodules involving skin or other sites with the characteristic plaque-like presentation may be seen. Diffuse blue nodules with a plaque-like presentation are present, and regional lymph nodes are enlarged. The lymphadenopathic variant is relatively severe in form, that it follows a very rapid spread and it involves mucosa more commonly, and skin is involved relatively less commonly here. Oral lesions are more common in lymphadenopathic variant. The transplantation associated includes 1 to 4%. We know in cases of hemodialysis or renal failure, disease failures, the patient undergoes for a renal transplant. In such cases, 1 or 2 years after the renal transplant, we know the transplanted patients are immunodeficient. They are trying to just improve their immunity after the transplantation. In that particular period only, after 2 years, this neoplasm of endothelial cells, endothelial blood vessels disturbance is seen. That is nothing but the Kaposi sarcoma. About 1 to 4% cases of transplantation show this Kaposi sarcoma. That is characteristic sarcomatous involvement may be seen. It may be involving either the organs, the skin, or the oral cavity. And AIDS-related Kaposi sarcoma, that is HIV infection, is the etiologic factor for causing this Kaposi sarcoma. It's seen in about 40% of cases. Only the middle-aged adults are more commonly affected by this disease. Characteristic clinical presentations of flat, pale, or slightly blue macules, red or purple macules may be seen, which are initially asymptomatic, and at a later stage they just tend to become nodular, ulcerate, and they are associated with severe excruciating pain once they become nodular and hemorrhagic. You can see the Kaposi sarcoma oral lesion there. It is a very proliferative one. It is nodular, it is ulcerated, and it is showing the features of hemorrhage involving the upper labial mucosa. And the cervical lymph nodes are characteristically enlarged in this form of disease. When you see the microscopic picture of a Kaposi sarcoma, initially it may present as small proliferation of small capillaries around a pre-existing vessel. There is an inflammation of a dilated blood vessel is present. The inflammation or dilatation of a blood vessel is seen. Surrounding that, new capillaries seem to develop in the early stages or the path stage where only a papule is seen. Okay, at a later stages, once the disease progresses from the papule or nodule to ulceration, at that stages, more prominent features like the proliferation of proliferation of capillaries, endothelial cell proliferation in lining the blood vessels are seen. These endothelial cell blood vessels, they are very closely situated to the skin, the adnexia, the surrounding structures. So the characteristic clinical manifestations correlate with it. Okay. Endothelial cell proliferation, that's the etiology here for causing the vascular neoplasm. Okay. Now we'll see the tumors of disputed origin. The granular cell myoblastoma. The granular cell myoblastoma, the origin of this tumor is disputed. Previously, it was thought that it is arising because of muscle tissue origin. So the origin of this granular cell myoblastoma, the neoplasm, was from the striated muscle. But later on, it was proposed that there is no relation with the muscle tissue, and the tumor arises because of some defect in the neural cell. So in such instances, this tumor has been grouped separately as a tumor of disputed origin. It is not clear if it is a true neoplasm, or it is a developmental anomaly, or if it is just associated with hyperplasia of that particular involved tissues. So the granular cell myoblastoma, basically the tumor, it's widely distributed throughout the body. Oral mucosal lesions just present as painless sessile nodular masses, which are sessile or pedunculated, maybe just 1.5 centimeter in size. They can arise at any age. Mostly the tongue is the commonest site which shows the granular cell myoblastoma, and the characteristic feature is the appearance of pale or yellowish discoloration on the surface of tongue. Along with the tongue, the other sides, it is palate, gingiva, labial mucosa, oral mucosa, floor of the mouth, gingiva, hard palate also show the occurrence of granular cell myoblastoma as painless nodular masses. Okay, here in the clinical picture, you can see the base of the tongue is showing some mass like a thing which is irregular in appearance. Okay, when you see the microscopic picture, it is characteristic in that the cells, the granular cells, they are relatively sessile. They are pale, about 20 to 40 micrometer in diameter. They appear to be having a eosinophilic stained cytoplasm and a small vesicular nucleus. The cell membrane of the cells is relatively distinct, and these granular cells, they just appear to invade or infiltrate the underlying tissues. Most commonly, the underlying tissue here will be in the oral cavity, will be a muscle or anywhere in the body. Granular cell myoblastoma is seen anywhere in the body, right? So it tends to just involve and spread to the surrounding tissues. So the granular cells appear to be having that capacity of infiltration or invading the adjacent tissues, so giving the characteristic malignancies. The treatment for granular cell myoblastoma is nothing but excision. Surgical excision of that tumor is carried out. Okay, the congenital epilepsy of newborn. Congenital epilepsy of newborn, as the name indicates, is another common neoplasm which has been grouped under tumors of disputed origin, because it is not clear if the neoplasm is arising because of which cell. Okay, most of the authors, they propose that the granular cell myoblastoma and congenital epilepsy of newborn are both the same tumors, but they show little bit minor differences in their clinical appearances. Okay, also known as Newman's tumor, the congenital epilepsy, as the name indicates, the tumor is present right from the birth, and it is different from granular cell myoblastoma in that congenital epilepsy has a predilection for occurrence in the maxilla. There is a maxilla shows the predilection, whereas the granular cell myoblastoma is seen in the tongue. So it is a rare lesion of the newborn. It is present at the birth. Initially, it presents as a protuberant mass of the maxilla. It is more common on the maxilla than on the mandible. That is the difference between the granular cell myoblastoma and the congenital epilepsy of newborn. So clinically, it just presents as a pedunculated lesion in the floor of the mouth. When you see the microscopic picture, large sheets of cells, they just seem to be closely packed with fine granular eosinophilic cytoplasm, and they are just distributed in the connective tissue. These cells are nothing but the tumor cells. Okay, the characteristic features of resemblance to the granular cell myoblastoma may be seen, but in granular cell myoblastoma, pseudoepitheliomatous hyperplasia of epithelium is seen, but pseudoepitheliomatous hyperplasia is absent in case of congenital epilepsy of newborn. The tumor, the appearance of tumor may be present at birth, but at a later stage. Few of the others, they propose that even the granular cell myoblastoma, which is seen in the surface of the tongue, lingual dorsum of the tongue, It may be present from the time of birth, but it is detected at a later stage. So both the granular cell neuroblastoma and Newman's tumor are one the same, but let us see the both may be same, but they are showing the similar picture of histologic features, but the clinical appearances are different. Treatment includes surgical excision of the tumor wherever it's causing problem. So that was all about the benign and malignant tumors of jaws. We'll see the metastatic tumors of jaws. Metastasis is nothing but a procedure which leads to spread of tumor cells. Suppose a tumor or a carcinoma of abdominal organs like carcinoma of gastric mucosa, carcinoma of involving the kidneys is occurring. The tumor cells from there, they just spread and by metastasis, and if they are involving the jaw bones, so we see the metastatic tumors even in jaws. So this spread of tumor cells may be by the hematogenous route, by the lymphogenous route, by any other route. The tumor cells gain access to the jaws and they just tend to spread in that particular region. The metastatic tumors of jaws are very, very uncommon, and they, if they occur, they may represent just about 1% of metastasis, and oral metastasis sometimes may be the first visible signs of disease seen in the oral cavity. Okay, the other sites, suppose the renal carcinoma is present, which is undetected without any clinical symptoms, and the metastasis of that cells has occurred to the oral cavity. So oral cavity may show the clinical presentation of inflammation, hyperplasia or associated clinical features, which we may not be able to diagnose few of the times. Okay, because we consider the inflammation in the gingiva to be a normal process occurring because of periodontal problems. Okay, if we investigate such a case deeply, we may correlate that the swelling or hyperplasia or whatever is seen, when we study it histologically, we may be able to diagnose the correct reason for that particular hyperplasia or increase in size of jaws. Okay. Jaw bones, basically the spread, as we know, the spread of tumor cells, hematogenous route is more common, and we know that hematopoietic bone marrow is there, which is responsible for the spread of tumor cells. When seen in the when we see the mandible, the hematopoietic, there is no active marrow present, especially only in cases of condylar region. At few sites you have the active marrow. These are the only sites which are responsible for causation of this metastatic tumors. The tumor cells just get deposited in that active marrow and they just proliferate and give rise to the clinical symptoms of metastatic tumor. And only the remnants of hematopoietic bone marrow are capable of dividing the tumor cells and leading to the metastasis. In case of dentulous patients, if we see, metastatic tumors are seen more commonly involving the attached gingiva. In case of edentulous patient, both the tongue, the alveolar mucosa, the floor of the mouth, the gingiva, almost all of the floor of mouth is affected. And the metastatic tumors, basically they occur at about 40 to 70 years of age, and the metastasis may be either to the jaw bones or to the oral soft tissues. Metastasis to the jaw bones is seen in cases of younger individuals, about 20 to 30 years of age, because of the remnant active marrow present in the mandible. Whereas metastasis to the soft tissues, it is present in older individuals above 50 years of age. The primary sources of metastasis to jaw bones may be cancers. The tumors occurring in the breast, tumors occurring in the kidney, the lung, the bone, they may be the commonest sites for this metastasis. Okay, the tumors occurring in any of these regions, they may just spread and involve the particular bone. Metastasis of tumor cells occurs, they just get deposited in the long active marrow of the mandible, and they just lead to metastatic tumor, or they may also get deposited in the soft tissue of the tongue and they just proliferate there. And for the jaw bones, the commonest and the closest site of metastasis is the carcinoma of breast, and the closest source of metastasis will be the lung tumors, because the lung tumors, they sometimes have a valvular mechanisms which they lead to spread of tumor cells directly to the soft tissue of the jaw bones. And the metastasis of tumor cells to the gingiva, clinically it presents as a hyperplasia or inflammation of the gingiva, which we may mistake as a normal hyperplasia seen with the periodontal problems. Initially, it may be asymptomatic, the hyperplasia or inflammation may be asymptomatic, or it may be associated with slight moderate discomfort or pain, or associated with sometime paresthesia of that particular area, and teeth affected may become loose and extruded. We as dentists, what we do is we just extract the tooth without trying to identify the underlying cause of mobility of teeth. Yeah, maximum of the times the mobility of teeth will be related to periodontal problems, but when you study the gingiva, the hypoplastic tissue, histologically, you see that presence of the characteristic tumor cells. So we'll be able to correlate or diagnose the carcinomas present in other sites of our body. Okay, so the painless swelling may be present, definite swelling may be present, it may be associated with the pain because of the characteristic metastasis or metastatic tumor cells. When you see the radiographic picture of such a metastatic tumor, clinically, radiographically, it may not present any symptom at all. Sometimes because of extreme proliferation, osteolytic cells may be activated, so empty radiolucent cells here and there may be seen in the radiograph. Or sometimes because of extreme proliferative activity, osteoblast cells may be activated, radio-opaque areas may appear on the radiograph. So mixed resemblance. When you see the microscopic picture, as I told you, when you study the hyperplastic tissue of gingiva to histology study, then you can correlate or see what tumor cells are present. What is the is the hyperplastic tissue normal inflammatory process, or is it showing any other characteristic features? So when we see the histologic picture of a metastatic tumor of jaw, it shows the characteristic typical features of the primary tumor. That is the feature of that is an indication of metastasis. Actually, primary tumor cells may be present. Suppose carcinoma of breast has spread to the jaw bones, and when you study it histologically, you see that the carcinoma test of breast, the epithelium and all are seen in the jaw bones, indicating a metastasis. The example is nothing but a primary ductal carcinoma of a salivary gland origin, which is arising as a result of metastasis of carcinoma of breast. Treatment for oral metastasis are only palliative treatment. No known surgery is required secondarily, unless it is associated with such a huge swelling that you have to go for a surgical excision. Radiotherapy and immunotherapy or chemotherapy the patient is put on to just help us regulate the symptoms. But sometimes when the carcinoma underlying of any other site is not detectable, it is not showing any symptoms, it is asymptomatic, when the oral metastasis occur early in the stages of the disease of progression of carcinoma, the oral metastatic tumors, if they appear early, you will be the person who diagnosed the metastasis by studying the tissue histologically. Okay, that's about the tumors, benign and malignant tumors of oral cavity.